Hello, everybody, and welcome to the Bariatric Surgical Training Committee Happy Hour. I'm just going to briefly share my screen here. My name's Laura Fisher. I'm a bariatric surgeon in Oklahoma City at University of Oklahoma. And before we get started, I just want to thank everybody for coming and remind you about the Fellow Project, which is a series of lectures first Friday of each month at 7 a.m. Eastern Time and noon Pacific Time. And those will fulfill your didactic requirements for the ASMBS Bariatric Certificate. So tonight we're going to be talking about the STAMPEDE trial, which is a trial looking at diabetes remission in bariatric surgery. And the specific article we're looking at is Bariatric Surgery versus Intensive Medical Therapy for Diabetes, 5-year outcomes. So our two guest discussants tonight, Dr. Jason Samuels is the current clinical fellow instructor in advanced GI, minimally invasive surgery and bariatric surgery fellowship at Vanderbilt University in Nashville, Tennessee. He did his undergraduate and medical degrees both at the University of Oklahoma and completed his general surgery residency at the University of Colorado, including 2 years as a T32 supported research fellow. He is a budding academic bariatric surgeon and has published several manuscripts in SWORD, JACS, and surgical endoscopy. And he received the Frederick L. Grover Clinical Award in Clinical Science Research from the University of Colorado. So he is striving to develop an academic bariatric surgery practice and clinical trials program to explore multimodal therapy in the treatment of obesity. And then Dr. Phil Schauer needs no introduction, but I will introduce. He is an endowed professor of surgery at Louisiana State University and is the director of the Metabolic Institute at Pennington Biomedical Research Center. He's one of the past presidents of ASMBS. He has performed more than 8,000 metabolic and bariatric operations on 5 continents around the world. His research interests include the pathophysiology of obesity and type 2 diabetes, as well as outcomes of metabolic surgery. He's the PI on 3 NIH-funded studies and has authored more than 400 scientific papers. He is the recipient of the SAGES Pioneer in Surgical Endoscopy Award, as well as the Cleveland Clinic Soanes Award, and that is a very abridged version. So with no further ado, I'm going to turn over our paper presentation to Dr. Samuels, and thank you all for coming tonight.
All right. Thank you so much for this opportunity to discuss really a seminal paper in the field of bariatric surgery. The STAMPEDE trial really set the stage for encouraging management of diabetes with bariatric surgery. A little bit of background, most of which will be reviewed for the majority of our audience, but as we all know, there's really no medical cure for type 2 diabetes. And not only that, but managing diabetes is a challenge with modern therapy. And patients who have especially moderate to severe diabetes really struggle to maintain control and achieve control even. And this leads to a number of macro and microvascular complications. A major cause for concern within diabetes is the development of cardiovascular disease. And there's been a number of studies that have shown that not only is poorly controlled diabetes, does that increase the risk of cardiovascular disease, such as heart failure and MIs, but as the associated comorbidities occur as well, especially such as hyperlipidemia, hypertension, many of these that we see commonly with our bariatric population, those risks for cardiovascular disease increases even further. There's a number of other consequences of poorly controlled diabetes as well, overall disability, kidney disease, of course, and ESRD, a number of problems with extremities such as amputations, digestive diseases, and infections. So it's really critical that we develop treatments for our patients with type 2 diabetes who have concurrent obesity. There has been a number of observational studies that have suggested that with bariatric surgery, we can achieve resolution of vast majority of our patients who have type 2 diabetes, approaching 80% or even greater than 80%. But without randomized controlled trials, really level 1 data, it's difficult to say whether that's causal or correlative. Are we really selecting our patients very carefully? Are these patients who are well controlled to begin with? Or are we really impacting patients compared to if we there continue with medical therapy? Some of the other specific questions that the STAMPEDE trial addressed was whether there's a benefit for patients with lower BMIs, lower than the NIH criteria of 35 or greater, BMIs 27 even or greater. What are some of the, importantly, do the benefits outweigh the risk of surgery? And this boils down to communicating to our endocrine colleagues and our primary care physicians the benefits over continuing medical therapy, showing that it's safe and highly effective. And really, what are the long-term benefits? If we were to follow these patients out for 5 years or greater, do we continue to see resolution of diabetes? So that brings us to the paper we're discussing today. This is from the STAMPEDE trial, bariatric surgery versus intensive medical therapy for diabetes, looking at 5-year outcomes specifically, Dr. Schauer and his group. The aim for this study was to determine the long-term efficacy and safety of bariatric surgery in treating type 2 diabetes compared to advanced medical therapy. And they hypothesized, and this is pulled from the protocol, that surgical therapy is more effective than advanced medical therapy for the resolution of type 2 diabetes in patients with a BMI between 27 and 43. It was a 3-arm randomized open label controlled single center study. They randomized patients 1:1:1 to advanced medical therapy or to advanced medical therapy with surgery, either a gastric bypass or sleeve gastrectomy. And I'll explain in just a second what advanced medical therapy means. They included patients between an age of 20 and 61. I mentioned the BMI criteria, and they specifically defined type 2 diabetes as an oral glucose tolerance test greater than, or at 2 hours greater than 200 with an A1C of 7.1%. Patients who had had prior bariatric surgery or foregut operations, so patients who were undergoing a revisional operation, so to speak, were excluded. And those with a number of medical comorbidities that really put them at a higher risk to undergo surgery were excluded as well. The primary outcome of interest, of course, was diabetes resolution. This was strictly defined as an A1C of less than or equal to 6% at 12 months. And of course, a number of secondary outcomes were also evaluated, such as time to diabetes resolution, again, using that A1C cutoff, what the change from baseline A1C was, the number of medications required at the different time points in order to obtain euglycemia, the incidence of in-organ damage in both groups, and changes in body composition, such as waist circumference, and importantly, quality of life measures were also recorded. For advanced medical therapy, this was strictly defined as following the American Diabetes Association guidelines for both lifestyle and aggressive medical therapy to achieve an A1C of less than 6% using the latest therapies at the time. This includes incretin and some of the other newer medications. This was a single surgeon, single center study. So the way the surgery was accomplished was standardized. So a sleeve was done, sized with a 30 French endoscope, measured 3 centimeters from the pylorus. And the gastric bypass was done with a 20 ml pouch, 150 centimeter root limb, and a 50 centimeter BP limb. The 3 groups were well balanced across the demographic variables, and ultimately 150 patients were enrolled. Impressively, they had nearly 90% 5-year follow-up, which is, of course, significantly higher than what we see on our average bariatric clinic. So we can all applaud the study coordinators in the study group for accomplishing that. There was one patient who crossed over from the medical group to the gastric bypass group at year 3, and one sleeve gastrectomy patient underwent a Roux-en-Y gastric bypass for the management of gastrocutaneous fistula. And looking at the primary outcome for A1C of less than 6%, unsurprisingly, there was a dramatic improvement compared to advanced medical therapy with surgery. The gastric bypass group had complete resolution of diabetes in nearly a third of patients and nearly a quarter of patients in the sleeve. I will point out that although the sleeve gastrectomy did not quite reach statistical significance, this was largely due to adjustments due to multiple imputations. They also found that type 2 diabetes of duration of less than 8 years was predictive of the primary outcome, as was the degree of weight loss. I think the change in percent weight loss being predictive is somewhat surprising, because I think a lot of times we tell our patients and we think that much of the improvements in diabetes is to a degree weight loss independent, but it does seem to be an association between the degree of weight loss and the amount of resolution. In looking at some of the other data from this study, the two surgical groups did have a dramatic improvement in their BMI compared to advanced medical therapy, surprising nobody on the call. And there was a slight difference between gastric bypass and sleeve gastrectomy, although whether that is clinically relevant versus just statistically significant, I think is up for question. And then looking at the graph on the right, in comparing patients who had a BMI of less than 35 versus those who had a BMI greater than 35 at the time of randomization, there was no difference between the two groups in those who underwent surgery. So patients with a BMI under 35 had just as much benefit for undergoing surgery as it pertains to the amount of improvement in their A1C. And similarly, they had a significant improvement compared to the control group. I think this graph here really is one that we can take to our patients and to our endocrine colleagues and demonstrate to them really the power of bariatric surgery. And what this graph shows, and I'll orient everyone here in just a second, is the changes in the number of medications required at 5 years after bariatric surgery. There's three groups here shown: the medical therapy group, gastric bypass group, and sleeve gastrectomy. And within each group, there's two columns, the column on the left being the baseline, the column on the right being 5-year data. And the different proportions of the column, the lowest proportion, the blue color, is the number of patients who are on no medical therapies. And the highest proportion on the top is the number of patients requiring insulin therapy. And what you can see is the patients who underwent medical therapy, of course, very few of them are on no medications, but essentially managing their diabetes with lifestyle alone. And that persists at 5 years of follow-up. And in looking at patients who were undergoing medical therapy, a number of patients, over half, were on insulin therapy. There was a slight improvement, although it's still a significant proportion of patients requiring insulin. If you contrast that to the two surgical groups, nearly half of the patients who had a gastric bypass were on no medical therapy or no medications to manage their diabetes at 5 years after bariatric surgery. Very impressive. And a quarter of patients who underwent a sleeve gastrectomy similarly required no medications after 5 years. And if you look at the number of patients who underwent surgery requiring insulin, with nearly half in both groups requiring insulin at the time of randomization, very few, just over 10%, were still requiring insulin at 5 years. I think this is something that's very easy to communicate to patients, that we will see a drastic improvement in the number of medications they require, and a number of patients will no longer require insulin. Of course, adverse events are something we need to consider, and thankfully they were very few in the surgical group. Just 4 patients required a reoperation. There was 1 fatal MI in the medical group and 1 stroke in the sleeve gastrectomy group. The most common complications are things we commonly see following bariatric surgery, such as mild anemia, which was more common in the surgical group, and hypoglycemia, also more common in the surgical group. And these are things that most frequently we're able to manage with lifestyle changes and occasionally a supplementation. So the take-home points for this study: of course, bariatric surgery achieves greater type 2 diabetes resolution than medical therapy. I think that's clearly shown. Roux-en-Y gastric bypass does appear slightly more effective at managing type 2 diabetes than sleeve gastrectomy, especially when you look at the number of medications required and the ability to come off insulin. Importantly, the reductions in A1C were equivalent into the groups as to whether patients had a BMI greater than 35 or less than 35. Again, reiterating the latest guidelines from the ASMBS that we should be offering bariatric surgery at a lower BMI from the NIH criteria cutoffs. And there were no difference in cardiovascular outcomes, although I'll discuss that being one potential limitation of this trial in just a second. But importantly as well, adverse events with surgery were thankfully very rare and often just mild anemia or hypoglycemic events. Of course, there's a number of limitations that are worth noting. First, I do wonder, this study really was around the time of exenatide and dulaglutide, and certainly predated some of the latest GLP-1 receptor agonist therapies, such as semaglutide and tirzepatide. And I wonder if this study were repeated today, how that would be different. Similarly, this was a single hospital study, and with 90% follow-up at 5 years. I do wonder if this was more of a pragmatic trial, whether the results would be replicated. Similarly, if patients undergo a duodenal switch or a SADI, which have been shown to have pretty profound improvements in type 2 diabetes, with the results to be even more dramatic. And lastly, I don't think the follow-up is quite long enough, and the event rate was not quite high enough to really make a comparison of cardiovascular outcomes. So that's another question that persists. I greatly appreciate this opportunity to talk about this paper, and I look forward to the discussion.
Okay, well, I guess I'll just jump right in. Jason, great job in summarizing the STAMPEDE trial. And also, you did a particularly good job at identifying the limitations. There's no trial that is perfect, that doesn't have limitations. I think you covered those very nicely. I'm anxious to hear what the fellows have to say or any comments, but just from a maybe historical perspective, I just might say that this was one of the first studies to randomize patients and compare, metabolic surgery outcomes with standard medical therapy of the day. And as Jason pointed out, there were several key findings. One, unequivocally, surgery was superior in terms of rendering long-term glycemic control compared to medical therapy. Patients in the surgical group got better over 5 years. In the medical group, they got a little better in the first year or two, but that A1C creeped back to baseline. And this is so important for a disease that is a chronic progressive disease that generally gets worse over time. So there's intervention that can just halt the progression of disease. That's pretty good. But if you have an intervention that actually makes patients better over a long period of time, that's very good. And surgery did this by creating greater control, but actually reducing medication burden. So the surgical patients, benefit in many ways, much better control, less medications. And that in of itself has important implications, not only for cost of care, but also quality of life, especially those patients on insulin. And we all know the degradation in quality of life that those folks have, not just in the painful shots, but in constantly monitoring their blood sugar and their diet and so forth. So that has positive implications. We also, in another study, we looked at the quality of life, patient-reported outcomes, and that was superior, especially with quality of life measurements that speak to general health overall. Surgery was superior. And then, of course, you have to clearly recognize that surgery is an invasive procedure. So what is the cost? And fortunately, in that study, we didn't have any real serious life-threatening, complications. That's critically important. Yeah. So those are the conclusions. And, our team, it was really a huge team effort at the Cleveland Clinic to put this together. And this happened because of a cooperation, not only between surgeons, but cardiologists, endocrinologists, statisticians. It was really a pretty large group of people that put a lot of time and effort, to put this together. And fortunately, since then, there have been several other small randomized controlled trials that have corroborated the results of the STAMPEDE trial quite well. In fact, there are about 14 small randomized controlled trials, and they all say just about the same thing. So that's pretty strong evidence. And then the last thing I'll say is that, in terms of the summary, is that surgery can cause long-term remission. And in terms of a disease, that's about probably as close as we're ever going to get for curing diabetes. If you can put in remission, that is, render patients close to normal, not exactly normal, but close to normal glucose homeostasis without medications, without all of the trappings that go with medications, the cost and disability and so forth. That's a pretty good thing. And surgery is the only intervention that can do that. You can get some short-term remission in patients with very mild diabetes with pretty strict dietary restrictions and exercise. But no one's been able to show that you can achieve long-term remission with exercise and diet. And you can even achieve a remission with medication. You can give patients very intensive medical therapy like insulin, and achieve what's called beta cell rest, where you give them very intensive medical therapy and then stop the drug. And there are some patients with mild disease that will stay in remission for months at a time. But it's never been shown that you can keep people in remission like that long term. And only surgery can do that. And that's important. If you look at the mission of the American Diabetes Association, it is to cure diabetes. And surgeons so far have the only tool, the only intervention that comes pretty darn close to that. Not in all the patients. In STAMPEDE, about 30% at 5 years. But remember, a key factor in determining remission is the status of the beta cell of the patient. And we all are familiar, and my first studies on this were bariatric patients who happen to have diabetes going into bariatric surgery, and a lot of them had very early mild diabetes. So we were able to achieve an 80% remission after several years in those patients. But in the STAMPEDE trial, we actually enroll patients with much more advanced disease, much more poor beta cell function. So 30% remission is what we achieved, but even that is pretty remarkable. So maybe I'll just pause there and see what kind of comments or questions we have from the audience.
Awesome.
Phil,
Much. Go ahead.
Adrian.
Sorry, I didn't mean to interrupt you, Adrian.
Wait a second, ladies and gentlemen. This is Adrian Dan.
so
Wait a
Phil-
second, I get the first word, Adrian.
oh, Jesus.
Adrian was one of my fellows many years ago. I knew he was going to be a star. He was a little diamond in the rough, I have to admit. But man, I'm so proud of him, what he has done in Akron and his devotion to our field, his many contributions, especially in education. I'm so proud of Dr. Adrian Dan. Adrian, take it away.
You're making me blush, and thank you. I appreciate it. I still am a diamond in the rough. That hasn't changed. I could start telling people how much of an impact you've had on my career, but it would go the entire hour. I'm going to try to keep it on task here. If you look at the study, and you and I have had these conversations offline with regards to the quality of the study and the cleanliness of a randomized controlled study versus some of the studies out there, some of which are also from your own series, that have huge numbers of patients, but are not randomized controlled studies or observational studies, but do have the power to show a difference. And that's not even my question, because we can say that there may be a difference when we look at those less difficult studies to do. But can you give our fellows a sense of the difficulties that it takes to do a randomized controlled study of this caliber, and why there are only 50 patients per group? I mean, if we look at the Rome study, the Mingroni study, they even have a lot fewer patients per group. What makes it so difficult? I think I have a sense of it from talking to you, but I don't think our fellows do, just how complex and difficult this can be to undertake from so many facets, including financial and ethical and so on.
Great, Adrian. That's a really, really good point, and thank you for bringing that up. First, before I talk about how difficult it is to do a randomized trial, especially when you're comparing a pill or a shot with surgery. But why it's so important? Why bother if it's so hard? And this is something that I'm sure many of you already realize this, but I can't hammer home enough how important it is to address the issue of bias. And bias comes in so many different shapes and forms. And this is why, the clinical trial is one of the most brilliant contributions in the history of medicine. It's an attempt as best we can to eliminate bias in so many ways. And just say, for example, the SOS study. Many of you have heard of that, right? The Swedish obesity subject study. It's a prospective study, not randomized, that compared bariatric surgery. At that time, it was the vertical banded gastroplasty. There were some gastric bypasses, a few bands, different type of band, compared with standard medical therapy. But the patients weren't randomized. So what they tried to do was they tried to match patients who had surgery with this control group, and they identified some 20 factors that would likely, play a role, right, in the outcome. And the outcome was death, heart attack, stroke, death. So there were 20 factors, age, body mass index, smoking history, gender, these things that we can pretty easily assess. But you have to understand that if the treatment group or the control group has an abundance of factors that enhance the effect of the intervention, or vice versa, the control group has an abundance of those factors, you're not comparing apples to apples, okay? So SOS is an example of matching known variables, okay? But what's really important, what people don't often understand, is the unknown variables that may have an effect that we don't know about. There may be some, biomarker, there may be some key demographic feature, it may be where the patient lives, what part of the country they live in. And so the beauty of a randomized trial is that when a patient is selected, there's a random opportunity that patient will land in either treatment group. So that if you do this with enough patients, it's a pretty good probability that the study groups are as identical as can be. And you can check this by looking at the key demographic features and making sure that they're pretty equal. The age, gender, degree of diabetes, body mass index, which you can't measure, the unknown. But there's a pretty safe assumption that by random selection, the unknown factors are likely going to be equal in both groups. Okay. So this is so important when you're really trying to assess the key impact of an intervention. Now, randomized trials are difficult to do, even if you're comparing, a pill to a placebo. But when you're talking about a pill or a shot compared to surgery, it's challenging because you have to have this concept called equipoise. You may have heard of that term, and that's more of an ethical term. And that is that you're going to this extent of conducting a trial because you don't know the answer. You're not really sure, and the answer is important. And so that's the concept of equipoise, that in the case of STAMPEDE, we didn't really know. Maybe the medical group, we had a suspicion that surgery was going to be more effective based on a lot of studies, right? But we didn't really know. Maybe the medical approach was going to be just as good. If medical approach is just as good as surgery, medication wins, folks, right? Because of the risk of surgery, right? So we didn't know. So you have to have this concept of equipoise, even to get a study like this approved by an IRB. And then the hardest thing is you got to find patients who are willing to enroll in a randomized trial. That's the hardest piece, especially a surgical and invasive treatment versus a non-invasive treatment. You have to have patients that, when they enroll, you flip a coin, Mrs. Jones, heads, you go to surgery, tails, you go to medications. And it's hard to find patients who are willing to do that. Okay. And so are so difficult. For Stampede, just to have any idea how many patients we had that met our inclusion. I mean, they qualified for the study. They had diabetes, they had obesity, all the exclusion stuff was out. Do you know how many we had to screen to get 150? Any ideas?
1,000.
Well, about 5 times that. A lot of patients. Thank goodness we had our electronic medical record, and we had some great research coordinators, to go through and identify people that met the criteria, and then they contacted them via email or phone call or, whatever. Yeah. Till we got these folks that would say, okay, I'm willing to do either, however the chips fall, and ideally stay in their treatment group for 5 years so we can really assess the long-term,
Did you have
benefit.
any patients who were randomized to surgery who couldn't finish the program, like were non-participatory or started no-showing or things like that? And how did you deal with that in your methodology?
Yeah, Laura, that's really good. What we were afraid of, and I should hasten to say that Stampede was funded by Ethicon Endosurgery, and the study cost about $7 million. It's a lot of money, isn't it? And the study actually paid for the surgery. That's why it was so expensive. About 80% of the funds went to actually pay for the surgery. Remember back in 2006, 2007, when the study started, there were a lot of insurance companies that, wouldn't cover the surgery. And so we wanted to make sure that if a patient was selected for surgery, they were going to get it and not have to depend upon, even if they had a benefit, going through the approval process and then, somebody saying, well, we're not going to cover your surgery because you didn't have, your psych eval wasn't good enough. Okay. So it was expensive. And we were concerned about what we call dropouts. And that's what Laura's talking about. Okay. You can have early dropouts and late dropouts. Early dropouts can be a killer for a study. Okay. And in the medical group, what happened was, we identified people that were willing to have surgery, and a lot of them wanted, surgery. If given the choice, they would pick surgery, and it was a free operation. And so we were concerned about the dropouts on the medical side, and we did have about 7 dropouts, people that were randomized to go to medical, and they said, no, thank you. The problem with that is they're already randomized, so you have to keep them in the study. I mean, you have to count them, okay? And using an intent to treat model. And if you have a large number of dropouts, it can really mess your study up, okay? But you can also have late dropouts, okay? You can have people that had surgery that decide after 2 or 3 years, thank you, I'm not going to participate anymore. So fortunately, that's what we call retention. Fortunately, we had a reasonable retention. We had about a 90% retention at 5 years. That's pretty good, actually. When you start getting dropout and the rate of 50%, then it really can affect the power of your ability to determine differences between the study groups. Does that answer your question, Laura?
Yes.
So Schauer, I really
Yeah.
wanted to, sorry.
Yeah, go ahead.
To piggyback off Adrian's question, I mean, yes, you've been phenomenal publishing research, and we all know that you're a great surgeon, but I think that you've also been very instrumental in moving the needle with the insurance companies. I guess, as somebody who is still relatively young in practice, how are you able to convince insurance companies to provide more coverage for patients? Because one of the biggest problems we have is access to care for our patient population.
Yeah, well, that's a great question, Julianne. And, when it's all said and done, it's access to the intervention that really matters. You can have, great studies, but if you don't have coverage, they can't get the remission that they deserve, right? So I think the greatest weapon, if you will, is data, and the highest quality data that we can get. And, for many new therapies, whether it's in cardiology or endocrinology, the entry cost of getting a drug, not just approved by FDA, for example, but covered by a payer, is a high quality level 1 study. Okay. Any new cardiovascular drug, it's got to go through study and to look at cardiovascular endpoints, and they're very expensive. So, in the early 2000s, there were some really, some decent studies. They were retrospective. They showed this big effect of surgery, but it hadn't really been compared head to head with conventional treatment for diabetes. So the accumulation of these randomized control trials, I think, has been, our biggest weapon, our biggest tool to convince the payers, that they got to cover this because it is so effective. And what we didn't really talk about was the cost effectiveness. And with a small study like STAMPEDE, it's really hard to show cost effective type data. But many other studies have shown that surgery not only is more effective, reduces medications, but actually lowers costs. And I think those are the arguments we have to keep pushing forward for better coverage.
Hi, Phil.
Hey, how you doing, Kenor?
I'm good. How are you?
I'm great. I see the Duke Chapel in the background. That's great. Many of my colleagues, and I want the audience to know I did my fellowship many, many moons ago at Duke, and that was so formative for me. Your fellowship year is so important, and the influence I got, from the attendings at Duke was just amazing. But go ahead, Kenor. Great to see you.
Great to see you too. So quick question, and this kind of a few people in the question and answer in chat have asked anti-obesity medications. So clearly we have come upon a generation of meds that is here to stay. They're working. I put my revision patients on them while we're doing a workup before we even think about surgery. I think it's going to be a game changer. But so there are also endoscopic therapies. So if let's say we're living in 2030 and you have a patient who's a BMI of 35, who's on oral medication controlled diabetes, and you could offer them tirzepatide or one of those cool new balloons that they can just swallow and poop out, or a sleeve. Tell me about your algorithm. Like, so when you think about how we're going to be practicing obesity, metabolic medicine and surgery in the next 10 to 20 years, where do you see this headed? And then my last prong to this is we're going to be adding in genetics, right? So at some point, we're going to analyze how all of these things interact with our genome and how epigenetics is affecting it. So, and I know you've got your fingers in all these pots already. So tell us a little bit.
Okay, so you want me to pull out my crystal ball, Kenor, right? And predict 2030, so 7 years ahead, right? Okay, well, let me just say, these new drugs are exciting, and no surgeon should be worried. Bring them on. the more tools we have for our patients, the better, okay? And, we're seeing weight loss effects we'd never seen before with drugs. In the past, the best you could get really was 5% weight loss. And so we're seeing, these drugs, the semaglutide, GLP-1 and Mounjaro, which is GLP-1 and GIP combination, get weight loss in the 15 to 20% range. Okay. Now, you're often going to hear obesity medicine doctors say, well, these drugs are just as good as surgery. Wait a minute. Okay, you guys need to stop them in their tracks. Okay. And these are the important arguments you need to throw at them. Okay. Number one, can you name me any anti-obesity medication that data, effective data, 0 on any of them. Now, the 15% we see with semaglutide, 2.4, and the 20% with Mounjaro is great, but that's at 1 and 2 years. Okay, let's see it go the test of time.
Oh, Dr. Schauer, I hate to interrupt you, but I think
to buy the drugs. I doubt very seriously.
I think your internet was breaking up a little bit. So
Okay, should I say that again?
yes, please.
The last 2 points.
Okay, sorry about that.
Can you
The last
name
2
me?
points.
Yeah, 2 points. Yeah, I'll
Yes.
summarize quickly.
Because I want to know. I was like
Yeah.
waiting.
Okay, when the medical doctors say, okay, Mounjaro is 20%, that's it. It's at 1 year. Okay, we have 10-year data. We have 20-year data for bariatric surgery. Okay, in the depending on the population, 25 to 30%. Okay, so the magnitude to the effect of the drugs is not surgery, and most important, the durability is not there. Okay, so first thing, still be on a drug. No one's shown that if you stop the drug, that they're going to maintain good glycemic control, or they're going to keep their weight off. Okay, that can cause remission of diabetes. So, your question, in 2030, that patient, in my mind, that patient is going to get a bariatric operation, because that patient, these operations, the risks have come so low, not 0 yet, but for the risk of essentially a cholecystectomy, you have a real opportunity for lifelong remission. Are you kidding me? I'll take that bet every day. Okay. But I'm really excited to see what happens, with the drugs and the endoscopic procedures too. The endoscopic procedures also lack the durability. The ESG doesn't quite approach a sleeve in terms of weight loss. And I doubt the durability is going to be as good as a sleeve. Okay. Maybe it's a little safer. Maybe it's a little bit lower cost, but we need to sort of follow that more closely.
The other thing we actually don't know about is the long-term side effects of those medications too. Obviously we're all hoping that patients will tolerate them well, but only time will tell us. So Laura, if you're okay.
That's a great point, Julianne. And let me just point out, sometimes it takes decades to find, just like it took decades to find out some of the issues we have with bariatric surgery. We know there's a metabolic bone issue. We know that there's some mental health issues in some of these patients long-term. There may be an alcohol issue. And with the drugs, it took 2 or 3 decades before we knew that some of these PPIs for reflux can have some very severe long-term complications.
Exactly. So we have one of the brave fellows here, Ricardo, who would really like to ask you a question. Go ahead, Ricardo, the floor is yours. You're muted though.
Still me.
Still muted.
There you go. Nope.
Can you
Can we unmute him? No.
So,
Yeah, we're not allowed to do it. There you go. Your mute came
I
off.
think somebody
good.
unmuted him.
Hello?
go ahead.
Hey, we can hear you.
Hi.
Yes, good. Sorry. My question is about the patients with BMI lower 30. What is the results about diabetes?
Okay, yeah, well, in STAMPEDE, we sort of touched upon that. We went as low as 27. And it was one of the first that pointed out that looked at, below 35. And when we looked at below 35 compared to above 35 BMI, we saw, no difference. In other words, the lower BMI patients enjoyed high improvement in time. There were certain people might lose too much weight if they had a gastric bypass at BMI 27. What happened was their BMI went to 22, and then it creeped back up to about 25. So we didn't see, big problems there. Now, 25 to 30, I don't know if we know much about that. There is a study out of India, which has not been published yet, from 25 to 35. These are people with diabetes. And it also seems to show a similar effect in that, 25 to 30 with diabetes. I think we just need more data, larger numbers. But I think from 30 and above, I think it's fairly safe to say it's a safe option.
Great, doctor. I appreciate it. Yeah.
And it just so happens that ASMBS, took a bold step forward and, put in their guidelines that surgery should be available for people with a BMI as low as 30 with a comorbid condition. And I will say, as a result of STAMPEDE at my institution at Cleveland Clinic, after our study was published, we got the Cleveland Clinic Employee Health Plan to lower the BMI threshold to 30 for patients with diabetes. And we're beginning to see, not as many as I would like to see, but we're beginning to see other insurance plans lower that BMI for diabetes because it just makes sense. Yeah.
Yeah, our Medicaid in Oklahoma just rewrote our guidelines, lowering it to 30, and specifically for two comorbidities or severe metabolic disease. So
yeah,
uncontrolled diabetes.
That's great. I would have liked to have had that avalanche happen sooner, but it's happening. We have these, 14 randomized trials now that include the lower BMI, and they all show the same thing. Yeah.
Dr. Schauer, what do you make of the finding that duration of diabetes seems to be associated with our ability to induce a cure with bariatric surgery? And do you know, are there some kind of biochemical markers that we should attempt to, or should study, or even begin using clinically to try and identify patients who would be at a greater chance of achieving a cure?
Yeah, really good question, Jason. And you were talking about, which is really important, is, predictors of long-term remission. And there's several that have been studied. We identified several in STAMPEDE. Some of them are just clinical, like duration of diabetes, patient's age, which is kind of a marker of perhaps the duration of diabetes, how many medications they're on, are they on insulin? These are kind of all like surrogate markers, I think, of beta cell function. Some people have looked at fasting insulin. You should see a pretty high fasting insulin in a patient with type 2 diabetes. However, as the disease progresses and the beta cells fail, they're hyper functioning early in the disease to maintain normal glycemia, but beta cells begin to fail when they're working too hard to produce insulin, and then you see a drop in fasting insulin. C-peptide, again, is another marker of that, the ability of the beta cell to produce insulin. So low C-peptide has been shown to be a marker. That's a test that's more difficult to get. I mean, it's possible to order that, but in fasting insulin too, but they're more difficult to get in the clinical setting. And then there's some very, provocative type tests, like a mixed meal tolerance test, glucose tolerance test that you can do to actually measure beta cell function. But those are really for research purposes. It's not practical to do that on your patients. But interestingly, out of all of them, the one that seems to correlate the best is duration of the disease, which is probably the easiest. Now, having said that, a lot of times patients themselves don't know when they became diabetic. It's estimated that by the time a patient's diagnosed with diabetes, they probably actually had diabetes for, many months or many years before. But if you can get an accurate measurement of the duration of diabetes, that's a pretty good indicator. Now, based on not that cohort of data, but a larger set at Cleveland Clinic, we came up with a calculator that actually Dr. Aminian, my colleague, who's now quite famous in his own right, came up with a calculator that if you know the duration of diabetes, the medications they're on, their A1C, you can come pretty close with an accurate measurement of the likelihood of remission. And that's based on the bypass procedure, the sleeve gastrectomy, those two operations.
Do you think there's a physiologic difference in diabetes remission between the different bariatric procedures?
Oh, definitely. Yeah, definitely. There's no question, that the bypass, STAMPEDE wasn't powered enough to show a difference in remission. However, at 5 years, about 30% for the bypass and I think 23% for the sleeve. The sample size wasn't big enough. But there are other studies, other randomized controlled trials that have shown, a difference favoring the bypass. The recent 10-year randomized trial that Paulina Salminian conducted in Finland compared the bypass and the sleeve. It didn't have a medical control group, but it showed not only better weight loss, but better glycemic control with the bypass, but it was a smaller sample. If you look at some of the larger observational studies, like the one David Arterburn published for the Kaiser healthcare system, where he had thousands of patients, but he matched, so it wasn't randomized, right? But it's probably level 2 evidence is pretty good. It showed better glycemic control with the bypass compared to sleeve gastrectomy. Yeah.
So Phil, I think we can say that we think there's a difference, but we don't know for sure because those are better powered, but this and the Rome study are cleaner. So I want to ask this question before we wrap up the hour here. What's the future hold? How can we get that answer? What can the fellows from today dream of in terms of that will eventually answer this question? So.
You're the best, Adrian. Gave me this nice softball question to end. Yeah. So when we talk about evaluating the effect of surgery, we've got quite a few small randomized controlled trials. And I should have mentioned early on, these are trials that are measuring markers of disease, surrogate mark. A1C is a marker, right? It's not always the case that a change in a marker actually reflects disease change. So what we're really concerned about is what Jason said earlier: macrovascular complications, microvascular complications. So things that are quite definitive: heart attack, stroke, death. And just because an intervention lowers an A1C in a patient with diabetes doesn't necessarily mean that's going to equate to a reduction in macrovascular or microvascular complications. Case in point, the ACCORD trial was a medical trial where they compared intense medical therapy versus standard medical therapy for diabetes. Intense medical therapy to drive the A1C as low as possible. Guess what? The people that got the intense medical therapy had a higher mortality. Go figure, right? So the best thing to do is to do a clinical trial where you're actually measuring those events: heart attack, stroke, and death. And because those events occur fairly infrequently, even in patients with diabetes, you have to conduct a large study. Okay, STAMPEDE was 150. So for a what's called a cardiovascular outcome trial, where your endpoint is not A1C but heart attack, stroke, death, you probably need a sample size of 3,000. Okay, so it means multiple centers, much bigger costs. That's the one thing we don't have in metabolic surgery that I hope someday we'll get. But it's not impossible. Coronary artery bypass surgery, there's over 100 clinical or cardiovascular outcome trials. And that's an operation that costs 3 or 4 times a gastric bypass. Those operations are $75,000, $80,000 easily, right? And there are 100 of those studies: carotid endarterectomy, aneurysm, and stents. There are multiple big RCTs for stents, but in the 70-year history of your field, there's not a single major multi-center prospective randomized controlled trial. And hopefully someday we'll do that. I think that will end any doubt, if there is any left, and it will likely lead to much better access for patients. Yeah. It's my dream.
Well, it looks like we're at the end. This was a very thought-provoking session. We're grateful to Dr. Schauer and to Dr. Samuels for spending the time with us. I don't know, Laura, if you had any announcements. I know Dr. Schauer had one that he mentioned.
Oh, thank you, Julia. I just want to invite all of you. Some of you may have already heard of our monthly webinar. It's called Metabolic Surgery Grand Rounds. It's the first Thursday of the month. It's usually at 6:30 p.m. Eastern Time, 5:30 p.m. Central. And it features usually a very key figure in our field: surgeon, scientist, medical doctor. And that individual gives a 20 or 30-minute talk about their work, their area of expertise. Then we have 3 panel experts, probe them deeper in terms of their knowledge and their discoveries. So it's fun. The audience can also type in questions. So please feel free to join us. The website is pbgrandround.org. P as in Paul, B as in boy, which stands for Pennington Biomedical, pbgrandrounds.org. So feel free to join us, and it's free.
And you guys will remember we have the Fellows Talk coming up on the 7th
Yes.
of April. And the next Bariatric Happy Hour will be on the 27th of April in the evening. It will be a discussion on concomitant hiatal hernia repair during bariatric surgery. So I think that's another session that's coming up that you guys will enjoy. Laura, sorry, you wanted to say something.
Oh, I was just gonna say one last super quick question from the audience. Is there going to be 10-year follow-up?
Thank you. And the answer is yes. And it's coming this year. And guess what?
Awesome.
It's even going to be more exciting because what we did after the Stampede 5-year, we joined forces with 3 other centers that had small randomized controlled trials. University of Pittsburgh, University of Washington, and Boston, the Harvard system, Brigham and Women's and Joslin. And we joined our forces together, and we are coming out with our data that will be presented in June at the American Diabetes Association in front of all the endocrinologists. And we'll have data from 7 up to 15 years of follow-up. So stay tuned on that. And I think it's going to get into a really good journal too. So stay tuned. Yeah.
Awesome. Great. April 27th, correct, Dr. Lloyd?
The next session, yes, the 27th. So it's always on the 4th Thursday of the month, just so you guys can remember that. It's easy.
Awesome. Dr. Schauer, this was amazing. Thank you so much. I don't know if you want to do a last salutation, Dr. Dan, before we head off for the evening.
I just want to say that I was looking for the little clap hand when I heard that there's going to be a 10-year follow-up to Stampede. I regard that probably as one of the major landmarks, cornerstones of evidence that we have in our field. And when I saw that the Rome group was able to come out with their 10-year study, which I had a chance to look at, Phil and I had a chance to look at ahead of its publication. I'm just so happy to hear that work is gonna come through to fruition for a 10-year follow-up. That's awesome. And I still can't find the little applause thing, but I'll just do it live. Thank you for all you've done for our field. And Laura, Julianne, amazing work in putting this session together. Thank you both.
Awesome. Well, we will see you guys next month. Thanks everybody for joining. It was really fun. Thank you, Dr. Samuels as well, and Dr. Schauer.
Good job, Jason. See y'all later.
Thank you, everybody.
Have a good night, y'all.